So now we'll call a young surgeon, Dr. Werner from Zurich in Switzerland, who will tell us about the tumor-draining pulmonary vein as a promising source for circulating tumor DNA in resected non-small cell lung cancer. Welcome to Canada, Dr. Werner.
Dear ladies and gentlemen, dear organizers of the Elixir Committee, thank you very much for the opportunity to come here to Canada, all over the Atlantic Ocean, and talk about this topic, about the tumor-draining pulmonary vein and its role as a source of circulating tumor DNA. These are my disclosures. It is actually very fitting to talk about this topic here in Canada, a country that has experienced the gold rush in the late 1800s. In Switzerland, we also do have plenty of beautiful mountains and rivers, and I have been fortunate enough to try looking for gold by myself in these rivers a few years ago. But I have to tell you, it is very frustrating. So you spend a day in the rivers, and what you find is basically just a few flakes of gold and no signs of a nugget. And searching for ctDNA in early-stage non-small cell lung cancer is probably very comparable to searching for gold in Swiss rivers. We know from a few of the phase 3 randomized controlled trials, the NADIM trial, the CheckMate trial, and the AEGEAN trial, that if ctDNA is identifiable, its clearance after induction chemoimmunotherapies is associated with pathological response and also with survival. However, we still see that a few patients with a complete clearance of ctDNA have a progression over the course. So ctDNA at the moment is not an indicator to de-escalate treatment, but rather maybe to escalate treatment to some extent. There have been data very recently published from the TRACER-X study that used an ultrasensitive whole genome sequencing-based ctDNA assay, which is a bit more promising since the non-detected ctDNA cohort has an excellent survival. However, the sensitivity of most commercially available ctDNA assays is often impaired by either sequencing errors or background signals, and the detection of ctDNA in early-stage non-small cell lung cancer is remaining a challenge owing to the low levels of ctDNA in plasma, usually far below 100 ppm. So the aim of our study was to assess the value of identifying ctDNA collected directly from the tumor-draining vein at lung resection, with the idea of going a bit further upstream where the ctDNA is coming from, where the concentration might be much higher. We prospectively collected blood samples from patients with stage 1 to stage 4 non-small cell lung cancer who underwent anatomical lung resection at the University Hospital in Zurich in Switzerland. We collected blood samples at 2 different time points. One at the beginning of surgery from the peripheral vein. Also at the beginning of, during surgery, we collected blood from the tumor-draining vein, and then we collected blood at first radiological follow-up, usually 4 to 6 weeks after surgery, also from the peripheral vein. And then we performed the targeted next-generation sequencing using the Oncomine precision assay by Thermo Fisher on all blood samples and also on the primary tumor. But overall, this was a tumor-agnostic assay, even though we had the results or the findings from the primary tumor. These are the oncogenes or the alterations that are targeted. It's roughly 50 targetable alterations that are covered by the Oncomine precision assay. We had a median age of 65 years in our cohort. More than half of the patients were male. The most common histology was adenocarcinoma. We had the broad spectrum of all UICC stages within our cohort. A lobectomy sample was usually the most common specimen that we had, where we drew blood out of. And 5 patients had neoadjuvant or had received neoadjuvant treatment. The mean cfDNA output, so here we're talking about the cell-free DNA, not the circulating tumor DNA, was at a median 34 times higher when derived from the tumor-draining vein when compared to the peripheral vein. This can be a bit also caused due to the manipulation of the lobe that we perform during surgery. But it was interesting to see that also the variant allele frequencies, and here we are talking about the ctDNA, was significantly higher in the tumor-draining blood when compared to the peripheral blood. The tumor-draining vein blood was also able to identify more patients who had targetable ctDNA or alterations than the samples from the peripheral blood. We had 5 patients with ctDNA identified in the tumor-draining vein blood and 3 patients with ctDNA identified in the peripheral blood at time of resection. And it has to be noted here that in all patients, in all 5 patients where we did have ctDNA in the tumor-draining vein blood, all these patients had an early relapse within 12 months after resections. The overall survival, although the follow-up was rather short, was also significantly reduced in both cohorts of patients who had ctDNA in the peripheral blood at time of resection, as well as in the patients who had ctDNA in the tumor-draining vein blood from the specimens. So of course, this study has certain limitations. It's a single-center study. We do have a limited sample size. And this targeted next-generation sequencing assay that we used is not an MRD assay, so it lacks sensitivity of identifying ctDNA at very low levels or at very low concentrations. But nevertheless, we can say using blood from the tumor-draining vein during lung resection might improve the sensitivity of an NGS-based detection of ctDNA when compared to just using peripheral blood. ctDNA from the tumor-draining vein may help to identify a certain cohort of high-risk patients who benefit from an adjuvant continuation or even an escalation of systemic treatment. And some novel assays, for example, a phased variant sequencing, could be also used on tumor-draining vein blood to improve the analytical sensitivity, and might be an optimal approach also for clinical trials. Of course, this wouldn't be possible with the support of a team in Zurich and also our collaborators. I would like to thank you very much for your attention, and I'm happy to take your questions.
There's a question on the right.
Thank you very much for your nice presentation. I want to ask you about the plasma volume, and it was the same with both approaches from peripheral and...
That's a good question. We usually drew 10 milliliters of peripheral blood, and from the resected specimen, there was a high variability on how much blood we were able to retrieve. So from lobectomy specimens, it's usually 4 to 6 milliliters that you can get out of it. And from segmentectomy, it's of course even less. It's usually 2 to 3 milliliters.
So despite having less plasma volume to isolate circulating tumor DNA, you had higher amount of circulating tumor DNA. I think also that is also important.
Exactly, this was corrected for the volume that we had.
Yeah, in your sample of the lobectomy, do you have analysis the sequential of block the artery first or cut the pulmonary vein first? There's a research published in the JAMA surgery, so that if cut the vein first will be better.
It's also a good point. We didn't have any standardized approach on this. Usually we of course cut the vein first, but I can't be sure that there wasn't a case where we could cut the artery first or where we stapled the artery first.
If I may, I think one of it was just kind of coming to me as you were presenting, and I don't know if this is true or not, but could you imagine that this comparative assay between the draining pulmonary vein and perhaps post-op from a peripheral blood could help differentiate patients who are shedding tumor DNA from the local regional disease? versus who are shedding from persistent micrometastatic disease that's unrecognized? Because this is the problem, right? Like we don't know where the ctDNA in the peripheral blood is necessarily coming from, and could this be a useful strategy to, especially using whole genome, where you could do comparative analysis of the types of mutations that you're seeing in the two different compartments?
That's a very good point. I've actually never thought about this, but you mean the idea of identifying whether there are still some shedding tumor cells remaining somewhere? I think this could be a good approach to compare where exactly the shedded ctDNA is coming from.
Question from Dr. Sepsi.
I do think that what was alluded to, I think the methodology of this is extremely important. We know that we have data on vein division first and outcome as well, and the surgical techniques of no-touch technique. So maybe as you consider this, and then some people actually advocate for intraoperative stuff to draw it out of an arterial line, because all of these things may actually matter. So maybe as you look for the future of some of these studies, maybe think about either getting it peripherally from arterial line instead of the vein. You can either stick with a small needle as you get inside the chest, the draining either superior or inferior vein. I don't think you're gonna have a problem with bleeding prior to even touching anything, maybe barely mobilizing the inferior pulmonary ligament. Or obviously, we have gone away from Swan's-Gunn catheters, but you could potentially cannulate the pulmonary artery, well, not the vein, but you would calculate, draw it from there. So, and just kind of see what the differences in these methodologies are. It's hard to argue, though, that you show different outcomes. But I think the methodology and no-touch technique and division of the vein first, I think those are important principles.
Thank you very much for this comment. I think this is absolutely true. In a next study, we would try to obtain ethical consent to puncture the pulmonary artery first without touching or even removing the lobe out of the chest.
Excellent. Thank you so much, Dr. Werner.